Okay, so good afternoon, everybody. Thank you for joining this webinar. My name is Anja Hermans, and I am working at the Institute for Medical Genetics in Tübingen, Germany, and I'm the training manager of the European Reference Network for Rare Neurological Diseases. I hope you can hear me all well. You're muted, but so our audio is on and you can hear us and see the pictures on our screen. So I will also share my screen now. Okay. So I will just give you some general information about the webinar. This webinar is part of our joint initiative together with the European Academy of Neurology and with the European Reference Network for Neuromuscular Disorders. We will have now approximately 35 minutes presentation and 15 minutes at the end for questions and answers. So if you have any question, just please write them in the question and answer section. The button, you can find it in the lower toolbar on the left side. These webinars are meant for a target audience which is composed of neurologists or residents, pediatric neurologists, geneticists from our member hospitals, from the R&D or from affiliated partners, or also from non-R&D healthcare providers worldwide. We will be, or we are recording this webinar, and we will put the recorded webinar on our internet site, and which you can see here the link for that, and the presentation, the slides of the webinar, we will put them as well. So at the end, we will have, your browser will open a post-webinar survey. So please take 2 to 3 minutes to respond to those questions there, because it provides us with very precious feedback of how we can improve and optimize the webinars. So just please give us your feedback. And now I'm very glad and happy to welcome Alfons Macaya from the Vall d'Hebron University Hospital in Barcelona. Alfons has a clinical expertise in genetics of developmental disorders, and his research focus is on early epileptic encephalopathies and pediatric motor disorders. He has studied medicine at the Barcelona Autonomous University and got his training in pediatrics from the Vall d'Hebron Children's Hospital in Spain. So he performed his PhD on models of excitotoxic injury in the developing brain, and afterwards he was a postdoc research fellow at the Neuroscience Institute at the Columbia University in New York. Currently, he is head of the pediatric neurology department and a professor of pediatrics at Vall d'Hebron Hospital in Barcelona. He was past president of the Spanish Pediatric Neurology Society and member of the European Pediatric Neurology Society Committee of National Advisors. He is member of editorial boards of several pediatric and pediatric neurology journals, and has published himself more than 150 papers, and his current H-index is 35. So thank you again, Alfons, for this work on the webinar and for accepting our invitation. I think there are many people interested in this topic out there. We generally see a big interest for the webinar, so indeed I'm very happy that these webinars or this educational initiative has seen the light and that is well working. So thank you so much. And now I will stop share my screen and you can just start.
Okay, hi everyone, and thank you, Sania, for your very kind introduction. Thank you everyone for joining and for the opportunity to participate in this webinar. Yeah, this would be the outline of this webinar. We will give some introductory data on ataxia and specifically on diagnostic algorithm in children. Move to the definition of the group of diseases we are going to deal with today, non-progressive cerebral congenital ataxia. Discuss the main clinical features, the etiology with an emphasis on the genetic heterogeneity, a few words on disease management and the conclusions. So the learning objectives of this webinar will be to recognize the presenting signs of NPCA, its comorbidities and associated outcome, to identify the main entities in NPCA and differential diagnosis, to assess the role of imaging in diagnosing these disorders, and also to identify the more common genetic etiologies in order to guide management and genetic counseling. So this will be a preliminary question to know your professional background. So please, if you could now take your time to answer this first question.
So here is the question and you can answer so that we can see what is your professional background. I will leave it for 30 seconds open. Okay, so here are the results.
So mainly neurologists and pediatric neurologists, as usual, I think. Okay. So I guess I can move.
Mm-hmm.
Okay, I can. Okay. So in terms of classification, we'll use something along the lines of our, and presented in the first webinar by Bart van Barenburg. And in children, it's quite similar to adult, and probably the only different category in addition to acute, recurrent, and progressive is non-progressive congenital, which is the topic of today. And in terms of anatomical location, again, same thing that in adults, cerebellar, sensory at various levels from peripheral receptors to parietal lobes, including dorsal columns and the thalamus, and also vestibular, quite rare in children. In relation to, seems cannot go forward for some reason. Now. So related to non-progressive congenital ataxia, I would like to start by presenting one of the cases that arose my interest in this relatively small subgroup of ataxias. And this is a boy that was referred at around 12 months back in 1999 because of these delayed motor milestones, titubation, and delayed speech. You can see there was some appendicular ataxia already at this point, can be appreciated. And we were a little bit surprised to find that MRI study at the time was absolutely normal. You can see here that ocular movements are quite preserved, and I would say normal at this point. And this is almost 20 years later. You can see that the ataxia is, well, relatively stable over time. Now, this is a university student with rather normal performance, maybe some mild dystonic features and some mild pyramidal signs on the exam. The current MRI shows maybe some prominent folia with mild upper vermian atrophy. So this family actually was subjected to a whole exome sequencing study. We didn't find any diagnostic gene. We found a candidate gene, but with no matches on matchmaker exchange. And because of questionable mineralization of the basal ganglia, red nuclei, and dentate, we concentrated on the NBIA gene screen, but was negative as well. So this would be a non-solved case, which exemplifies the patients we are going to discuss this afternoon. So in general terms, when we consider the clinical diagnostic algorithm for early onset ataxia, this is the algorithm that was recently endorsed by the EPNS Cerebellum and Ataxia group. You can see the publication on the right side at the bottom, and this has been proposed as a way to proceed to diagnosis in children. And you can see that after taking the clinical assessment, maybe if the patient cooperates, try to quantitate the ataxia with a scale and excluding a positive family history, you usually end up with brain MRI. Brain MRI can show some specific hindbrain abnormalities in some cases. And this is actually our first question of the webinar. Let's hear about your notion about that. Which among the following is not a hindbrain anomaly associated with early onset ataxia?
Okay. So, do you see the
Have
question?
two questions at the same time?
Yeah.
Okay, no problem. This would be number 2, yeah, actually. Yeah.
We can start it again for the number 2 afterwards. You can just now vote for the first question. What is the most common genetic cause of congenital ataxia?
Oh, okay. So Sanya, should we have the votes for number 2 as well?
Well, because I actually didn't plan like this, but if now some people have answered to the second question and to the third one, but maybe we can show the questions again a little bit further so that we can see how the attendees respond afterwards after the you have said some more words on the content itself. Okay. So I think now we can stop the poll and show the results.
Okay, so we have, for those joining the webinar later or listening to the webinar later, I will comment on those 2 questions. The first one is, what is the most common genetic cause of congenital ataxia? And the 2 more voted answers were in first, autosomal recessive inheritance, 43% of the votes, and de novo heterozygous mutations 29%. And regarding the second question, which is relevant to the following slides, is which among the following is not a hindbrain anomaly? And quite correctly, most of the attendees have voted the Blake-Boucher cyst, which doesn't associate a cerebellar anomaly per se. So then I will move to the next slide. And these are some examples of those hindbrain abnormalities that we were considering in the algorithm. And in the upper right panel, we have a classical Dandy-Walker malformation with the enlarged and cystic posterior fossa and hypoplastic cerebellum. This is quite typical for this malformation. We have also the molar tooth malformation with the elongation of the superior cerebellar peduncles and the enlarged interpeduncular space. Then on the bottom left, we have the dragonfly sign associated with pontocerebellar hypoplasia, which actually is this prominent vermis in the presence of atrophic hemispheres. We have also the stripes, pontine stripes in RSACs of the Charlevoix-Sanguinet type. And finally, we have rhombencephalosynapsis, a type of dysplastic cerebellum associated with several different syndromes. So if we get one of these malformations in imaging, we can sometimes use specific gene panels, even though these days whole exome sequencing and whole genome sequencing are rapidly catching up, both in coverage, in cost, and in turnaround time. So if the brain MRI turned out normal or with non-specific abnormalities, we would suggest to go to array investigation, especially if there are some phenotypic anomalies or intellectual disability, followed by NGS techniques. And nowadays, probably many NGS techniques give us information as well on the presence or absence of CNVs. So both can be pulled together in one single test. So this would be the algorithm. For evaluation, the SAR scale has been endorsed by also the cerebellum group at the EPNS, and has been proved by the group at Groningen here with Deborah Sival and her group, and has been proved reliable and meeting criteria of validity for these early onset ataxias. And, however, one important point is that we should take into account the developmental score, the variation in developmental score across ages in childhood, which is an important point. Still, normal reference values need a more broad study with more children to be determined. And we have also to consider that many of these patients display developmental delay and intellectual disability, and therefore it can be difficult to administer in some cases. So now centering on today's topic, non-progressive congenital ataxia. This was defined as the disorder affecting children with early evidence of cerebellar ataxia, and we have to underline cerebellar, without progression and follow-up, and even the tendency to gradual improvement. So this would exclude lesions following, acquired lesions in the perinatal period, malformations subretentorial, some syndromes which include ataxia but defined syndromically, and also postnatally acquired neurological diseases. In addition, also hindbrain malformations, as the ones that we just reviewed, are also excluded from this diagnosis. And this was quite well studied and developed by the group in Zurich and in Rome with Enrico Bertini and Ginevra Zani and colleagues. In terms of history, the concept was introduced by Frederick Batten, one of the fathers of pediatric neurology, back in 1905. And then some more characterization was aided by Norman, also in the UK in 1940. And finally, the work I referred to in 1998 by the Swiss group, where they published on 34 cases of their own, plus a review of preceding publications, and emphasize the age-specific clusters of symptoms in congenital ataxia and the non-progressive character of this condition as a group. There's been nevertheless some other approaches, and for instance, this is one of recent work where the authors acknowledged the congenital cerebellar ataxias as a relatively small autosomal recessive cerebellar ataxia subset with this infantile onset. So there is some overlap probably among the conditions we are discussing and very early onset autosomal recessive progressive ataxias. And there's also this other work in brain referring to ataxic cerebral palsy, which is not a preferred term usually, but for some authors, if we encounter a early motor disorder with ataxic features and no regression in absence of prenatal injury, that this could be also a term that we would face when referring to the same group of patients. So this is question 3, which I don't know if most people already answered, but if you wish, you can take a few seconds to complete the survey.
Yes, you can answer maybe now only the question 3.
Okay.
Couple of more seconds, we will leave it open. Okay. So here are the results.
Okay, so the answer was about typical clinical features. And first one was seizures are rare, only 10%, and this is correct because seizures are frequent in this group. Most patients walk unassisted before age 10, 20%, and this, in my view, it's the correct answer because most of the patients, the ataxia is not so severe as to not attain independent walking. Oculomotor anomalies are a late clinical sign, correctly, because this is quite common in the first stages of disease. And normal cognition occurs in more than 50%. Usually there is a comorbidity of cognitive deficit in those patients. So this would be the general outlook for this group of diseases. Okay, so going back to the clinics, the early signs in the first year of life in infancy are hypotonia. Hypotonia can be really severe, sometimes can be even confused with a neuromuscular disorder in the first months of life. There is motor delay. There is very often speech delay as well, and abnormal ocular movements can be also quite conspicuous in the first year of life. In older children and adults, there is a high prevalence of cognitive and language impairments. Seizures are quite common as well. The ocular signs may persist, as well as behavioral disorders, microcephaly, and in a few cases, not the majority, but in some cases, spastic or dystonic motor signs. The differential diagnosis of NPCA is mainly with other congenital ataxic syndromes. Sometimes there are destructive lesions of the cerebellum, which can be diagnosed time after birth and pose a difficulty as to what was the timing of the lesion. Also progressive cerebellar with onset in infancy, as we already have mentioned. Sensory ataxia, and also white matter disease. And I'll show you a few instances of each. These are patients from my own clinic. You can see in many cases the magnitude of the hypoplasia or atrophy of the posterior fossa structures, and all of these were preemie babies, 24 to 27 gestational weeks, and you can see that many have, or all of them have intellectual disability associated to their ataxic syndromes. Not surprisingly, since abnormal cerebrocerebellar circuits result from this early cerebellar dysfunction and therefore impair learning processes. Second is progressive ataxias with onset in infancy. There's a few autosomal recessive, some of them quite more frequent in children like ataxia telangiectasia, and some of the other spinal cerebellar atrophies with recessive inheritance, and some of them it's debatable whether they belong into the progressive or static and therefore non-progressive clinical forms. In fact, distinctions are so difficult that there's been by those authors in France, Stéphanie Valens and colleagues, who have proposed the term very early onset slowly progressive ataxia in young children, because sometimes it's very difficult to distinguish between both scenarios. And we have here an instance of one of the patients that we included in a study that I will mention in a few seconds. And this is this girl, which had an ataxic clinical presentation since infancy. You can see how it worsens with the Romberg maneuver, and in a way suggesting that this is a sensory ataxia, and this was a girl with a piezo2 biallelic mutations, and you know that piezo2 is a non-selective cation channel, which is actually retrieves it transmits the mechanosensation, and therefore their mutations result in loss of proprioception and discriminative touch with ataxia, dysmetrial scoliosis. In some cases there is congenital arthrogryposis, and these are the variants in the girl you just saw. And then there is this other patient which also came to our attention because of this quite prominent ataxia. He had just a mild, maybe questionable atrophy according to our radiologists, yet the diagnosis was recessive mutations in GJC2, which is connexin 47, and it gives rise to hypomyelinating leukoencephalopathy type 2. And in those patients, sometimes ataxia may precede and overshadow the spasticity of their leukoencephalopathy. With regard to NPCA itself, imaging usually is normal in some cases, or shows non-specific hypoplasia of the vermis or hemispheres, or sometimes we call atrophy those findings, although it is not clear whether this is atrophy or just is underdevelopment of the cerebellar folia as a result of the genetic mutations in these patients. We already discussed this, you answered this question, so will just now, if Sania, if you agree, comment on previous answers. And regarding the most common genetic cause, and the most common one is de novo heterozygous mutations, followed by autosomal recessive. So I think that this was the other way around in the survey, and we will discuss now why is that. One of the most comprehensive studies on NPCA was by this collaboration in the Handbook of Clinical Neurology with Bertini, Zani, and Bolshauser, and you can see that the number of genes have already been associated with this disorder, and many of them are de novo heterozygous, and some of them are recessive. Actually, this is in total. In recent years, you can see that it's over 35 genes if we consider both genes which have been confirmed and a few candidates from the last 2 years, which still are awaiting replication in, let's say, a second or third patient. And as in other developmental disorders, we had some genetic diagnosis before 2010, which usually were associated to familial cases with linkage analysis and positional cloning, or direct sequencing wherever we had a biomarker that would make a good candidate for a given gene. But after NGS availability and explosion in the last decade, you can see the exponential and number of genes that have been reported for this group of conditions. Yeah. So if we try to put together those genes, we can see in this functional association network using the string software that the most connected genes belong to pathways related with ion channels, synaptic proteins, mostly glutamate receptors. So very much like we know in adult and some of the adult ataxias, one of the more important pathways. And if we look into the biological processes which are enriched in where these genes are enriched, we can see that there is synaptic transmission, some chromatin modeling, agrigophagy, and cerebellar Purkinje cell layer morphogenesis. So this might also explain why there is this, let's say, pleiotropic effect of mutations in different neural systems and sometimes even outside the nervous system. So I will now refer to a study that we undertook in our hospital. These are 21 subjects that were evaluated for NPCA. I will not repeat the inclusion criteria because they coincide with the diagnostic features that I already mentioned. All of them had a metabolic screen, and I just wanted to use this slide to reflect that most of the patients had hypotonia, either when we saw them or as a clinical significant antecedent, with motor delay. That MRI was often normal at the beginning, sometimes with atrophy, but many times was normal, and that most patients attain independent gait before 5 or 10 years at most. Some of them remain non-ambulatory. And looking at the follow-up, see that cognitive dysfunction is almost constant. Seizures sometimes. Spasticity is not so frequent, but hyperreflexia, it's common. Oculomotor disorder persists over time, and there can be some additional features, as I mentioned, but you can see that on MRI, usually there is some atrophy, but which tends to become eventually to become stable. And one important feature in those patients is that usually there is no, according to all the authors that have worked on this, there is no correlation, clinical radiological correlation. Many of the patients have such a cognitive dysfunction, or maybe because of the age, that we could not use the SARA score in everyone. So because of the high incidence of de novo heterozygous in this disease group, we used trio analysis of this whole exome sequencing. Two of them were excluded. These are the two patients that I already showed with the sensory and white matter disease and sensory ataxia, and we got those percentages of diagnosis of negative patients thus far, and patients with candidate genes, 3 out of the 19 remaining patients. 3 of them had autosomal recessive conditions, and 8 had de novo dominant. So I will just now present a few examples of each one of the groups. In the first one would be disorders where ataxia is the leading clinical sign. The gene associated with the patient that I'm going to show you is CAGNA1A. You know that encodes the alpha-1 subunit of the voltage-gated neuronal calcium channel. And you also know that it's associated with different phenotypes, including familial hemiplegic migraine, mostly gain of function, episodic ataxia, mostly loss of function mutations. Biallelic mutations can give rise to an epileptic, early infantile epileptic encephalopathy, and expansion of polyglutamine tracts to spinocerebellar ataxia 6, in addition to some reports of other more or less common phenotypes like benign torticollis in infancy with upgaze or without upgaze, generalized epilepsy, or some cases of hemiplegic hemiplegia of infancy. And this is this patient with intense hypotonia. You can see some apraxic or dyspraxic movements, some titubation of the head very early on in life. This is just 3, 4, and 6 months, the 3 clips. Here the difficulty in at 1 year of age in trying to hold his head or adopting the sitting position. And finally at 5 years of age, this patient is already now over 10 years and he did not attain independent walking. And this is his MRI, where I think you can see the progression of Fermi's atrophy. Not very dramatic, but there is no question there is some progression. And this is the genetic study with the deletion of a phenylalanine, and functional analysis showed a decrease in the voltage threshold for channel activation, allowing therefore higher calcium current densities in a wide range of depolarizing voltages. So there was a functional confirmation of this case, which was appeared de novo. This patient had also one of the characteristic clinical features, which was seizures and coma episodes after minor head trauma, like bumping in the head with a soccer ball, something like that. And then no, he never improved with treatment with acetazolamide. Another classical ataxic syndrome is linked to mutations in ITPR1. ITPR1 You can see again this patient with ataxic gait, here at age probably 14 already. And this patient had Gillespie syndrome, which is where you can see here also the appendicular ataxia with dysmetria and tremor. And one characteristic feature in this patient was the aplasia of the papillary sphincter, which is sometimes confused with aniridia, and the scalloping. You can see here in the bottom right of the iris, and something that is seen only in Gillespie syndrome as well as in ACTA2 related multisystemic disease. And ITPR1, you can see here this cartoon where you can see that this is a intercellular transmembrane calcium release channel, and it also interacts with carbonic anhydrate-related protein CAH, this binding domain, and it interacts with it's responsive to IP3, inositol 3-phosphate. So this is one important entity which is seen quite often in patients with NPCA. And one interesting thing is that there are dominant negative mutations that give rise to the Gillespie syndrome, which are gain of function mutations, and as opposed to null alleles, which are partial loss of function. So you need to be either biallelic or monoallelic with gain of function to develop ataxia. Another entity that we encountered in this series of patients with was mutations in CA8. This was a patient with homozygous mutation in CA8, and there is some lesson to that, because the exome was negative, interpreted as negative initially, but we performed runs of homozygosity despite there was no known consanguinity, and we found some homozygous regions, and we found a mutation, a homozygous mutation in CA8, which was the cause of the ataxia. And just to remember that we are aware of 3 different disequilibrium syndromes of congenital ataxia with mental retardation, with propensity to predisposition to quadrupedal gait, which are FLDL receptor, WDR81, and CA8. The second group was in this series was NPCA as part of complex neurodevelopmental disorders. And we can see here a patient with mutation in syntaxin binding protein 1. You can see the ataxia and the tremoric quality of the movements, and went on to develop a autistic spectrum disorder and epilepsy, but quite late at 4 years of age. And you can see here the common phenotypes with syntaxin binding protein 1, but we have to remember that sometimes ataxia can be the presenting symptom. Another gene important in this group is EBF3, which is also a gene important for neuronal development, for neuronal specification, and maintaining the neuronal phenotype in adults. Haploinsufficiency has been associated with, you see, this developmental anomaly, and ataxia was described in 6 out of 7 of the original patients associated with oculomotor apraxia. And similar to PPP2R5D, this is just to illustrate that a number of genes that are involved as transcription factors and important during development can present as congenital ataxia, usually associated with intellectual disability, in this case modulating the PI3K AKT pathway. And just a final one, congenital ataxia associated to CTBP1. This one has a phenotype which is characteristic for the tooth enamel defects, in addition to developmental delay, hypotonia, and ataxia. And again, it's a transcriptional regulator which interacts with chromatin modifying enzymes. Last, couple of examples with metabolic disorders presenting as non-progressive cerebellar ataxia, and we have succinic semialdehyde dehydrogenase deficiency. This is a static encephalopathy, which can be sometimes episodic, but many patients are static with cognitive deficiency. The language deficit is quite typical for those patients. It is clearly out of proportion of the other cognitive deficits: hypotonia, epilepsy, hyperreflexia, and ataxia. There is a biomarker, as you know, and this is one of our patients which started with poor equilibrium at 2 years and developed a complete ataxic syndrome and a severe dysphasia with a big nystagmus on vertical gaze. And my last example here is congenital ataxia. This is a girl that, let's see if I can, no, sorry, this, okay, anyway, this girl, I saw her before 1 year of age. She was unable to sit still, and there was a very prominent titubation and nystagmus. And only 17 years later, we found in exome sequencing this biallelic mutations in this transporter for several for manganese, zinc, and also associating glycosylation disorder. The same molecular defect causes both deficiencies. It was described in the Egyptian population, but later on has been described also in patients from other ethnic groups, including a publication from Germany. And it's interesting that a missense variant in this gene is associated with idiopathic scoliosis. In terms of therapy, there is not much that I can say or that we can offer. Of course, physical and occupational therapy. I'm not really aware of any non-invasive stimulation technique in this group of diseases, such as transcranial stimulation or anything. It has been published that for the calcium alpha-1 subunit channel, the combined use of pulses of corticosteroid and hypertonic solution during the acute decompensations can limit or prevent damage, because this can be a progressive, in some cases can lead to coma and then further disability. Acetazolamide has been also proposed, but it doesn't seem to work. For the metabolic, there's been some debate on the use of vigabatrin for SADH, but not really effective in most cases. So as conclusions, this group of ataxias have a very early onset on the first year, more often hypotonia and motor delay. Usually, patients have global developmental delay and abnormal ocular movements. Ataxia is essentially non-progressive, but other complications are seizures, cognitive, behavioral impairments, and in this sense, they overlap with other developmental encephalopathies. Imaging ranges from normal to isolated cerebellar atrophy or hypoplasia. There's over 35 associated genes with increasing heterogeneity. And although previously considered to fall into the autosomal recessive infantile onset spinocerebellar ataxias, genetic counseling has to consider the high incidence of de novo heterozygous, and prognosis towards stability rather than to degeneration have to be also reminded. So thank you for your attention.
Okay.
And maybe there's questions at this point.
Yeah, we can switch to the questions and answers session. Do you see it, Alfons?
Okay. There's a question and answer as a very positive. Is Alan Thomas?
Yes,
from
this
Wales. Yeah.
A patient representative of the ataxia patient group from Wales.
In Wales, great. And it states that we pride ourselves on sharing information to allow a more informed and empowered patient. It seems that there are a lot more ataxia brands, quote unquote, genetic causes, than ataxia patients are aware of. I myself have slight ataxia from birth, diagnosis as 25, SPG7, diagnosed 2 years ago. Well, yes, there is, of course, this overlap in ataxia and SPG, which I didn't emphasize in this group because maybe it's less prominent in this group of diseases. But it's true that most series described maybe have two patients with the same genetic defect. The most usual situation is a lot of different genetic diagnoses in congenital non-progressive ataxia. So yes, more than suspected and probably increasing as yet. I don't know, I don't see other questions.
Yes, do the participants have more questions? Please write them in the Q&A session. We will wait another 1 or 2 minutes if there are other questions. In the meantime, I would like to recall the next webinar is also on ataxia. It will be in 2020 on January 14th. It will be also on ataxia and this on inherited ataxia by Paola Giunti from UCL.
Okay, there's another question. If you want me to answer now.
Yes.
Sania, yeah. Whether we have considered ATP13 gene as candidate, and yes. The thing is that we have not approached those patients with a list of candidates or a gene panel. We have used ATP1A3. Okay. We have not approached those patients with a list of candidates. We performed whole exome sequencing and then looked for both de novo, because these were trios, de novo mutations or compound or heterozygous or homozygous. So we had no real candidate. Of course, we looked into those kind of genes that can give us ataxia as part of the phenotype, whether episodic or chronic and progressive as well.
Okay. Are there more questions? So it seems that we don't have any questions left. There is also in the chat box something, but I don't know. No. So, okay. So with this, we can close the webinar. I hope you liked it, and please take 2 minutes time to respond to the survey. I wish you all pleasant and restful Christmas holidays, and see you in January again with another webinar. Thank you, Alfons, for giving this webinar. Thank you.
See you and thank you all.
Thank you. Bye-bye.
Bye.